I'm audible and visible to all my dear students. Can I get a quick thumbs up from all of you? So welcome everyone on this dermatology session with me, Dr. Chesta Aggarwal. Can I get a quick thumbs up from all of you? So we have a NEET PG 2023 batch which is about to start. That is specifically a TND batch for the repeaters. We have a module 1 batch that is for the NEET PG theory comprehensive batch, and we have module 2 which is for the high yield division. Now I welcome all my students. I am Dr. Chesta Aggarwal, your NEET PG educator on the best online platform, that is Unacademy. I have myself scored a good rank in my NEET PG and I will definitely help you out with the same. So let's start with the MCQs of the today's session. We have a very interesting MCQs which is based on a lot of important fact. Starting with the first question of the today's session. Find the incorrect statement regarding the condition shown in the image below. So let me very quickly show you the image first. So this is the image. I hope I am audible and visible to all of you. This is the image of the patient's foot. You have to tell me which of the following is the incorrect statement regarding the condition shown in the image. Pressure bearing or friction areas most commonly affected, often associated with malodor and maceration, mainly caused by Corynebacterial infections and usually associated with anhidrosis. Now very nice, this is a very classical condition which is known as pittate keratolysis. You are right, all of you. It's a condition which is known as pittate keratolysis. And please remember, it is associated with Corynebacteria infection. The infection of Corynebacteria species. Now what happens whenever a patient who wears a foot shoes for a very long period, the sweating occurs, there is maceration of the skin of the plantar surface, and this will give rise to increased entry of Corynebacteria inside the epidermis, causing its digestion and forming these punctate lesions. So very classical of pittate keratolysis, but please remember it is associated with hyperhidrosis. It is associated with hyperhidrosis, not anhidrosis. It is associated with hyperhidrosis, not the anhidrosis. Next question. Which of the following organism causes erythrasma? Anyone? Which of the following organism causes erythrasma? Corynebacteria diphtheria, Corynebacteria minutissimum, Corynebacteria tenuis, or Diphtheroids? What is the correct answer? Very nice, Jai, Ashima. Very well done, all of you. Now, erythrasma is again a Corynebacteria infection which occurs secondary to Corynebacteria minutissimum, while Corynebacteria tenuis causes an infection which is known as Trichomycosis axillaris. It is an infection which occurs secondary or it occurs on the axillary hair, where you see a yellowish concretions which gets deposited on the hairs of the axilla. So Trichomycosis axillaris. Trichomycosis axillaris. Next question. Wood's lamp light is used in diagnosing of? Swati, Jayashruti, Ashima. Anyone? Very nice. The Wood's lamp light, which is based on the principle of fluorescence, it helps us diagnose tinea capitis, where we see a very characteristic bluish green or bluish yellow fluorescence. It is not positive in any other fungus, but it is positive with tinea capitis because the most common species of tinea capitis, that is microsporum, shows the property of fluorescence. Can anybody tell me that on what wavelength, what is the wavelength of ultraviolet rays which is emitted by the Wood's lamp light? What is the wavelength of ultraviolet rays emitted by this? Anyone? Please tell me the correct answer here. Wavelength of light produced by Wood's lamp is 320 nanometer, 360 nanometers, 400 nanometers or 480 nanometers. Which of the following is the correct answer? Amazing, very easy and very interesting. I think everybody have given this. The answer is option number 2, and we have a mnemonic to remember this, and the mnemonic is the number of days in a year. Number of days in a year. So the exact wavelength which is emitted by a Wood's lamp is 365 nanometers. The exact wavelength which is emitted is 365 nanometers, and the answer to this is 360 N, which is the closest possible answer. Now UV radiation, it includes, or the UV rays which are emitted by Wood's lamp, they pass through a filter. That filter is made up of tin, chromium oxide, nickel oxide, silicon, copper oxide, barium oxide or zinc oxide. Which you feel is the correct answer for this particular question? Tin, chromium oxide, nickel oxide, silica, zinc oxide. What is the correct answer? Ashima, Jay, Ruhi, Swati. Very well done all my dear students. Wood's lamp filter is made up of. Wood's lamp filter is made up of. The answer is nickel oxide and barium silicate. So Wood's lamp is a handheld instrument, something like this, with a rectangular face and a handle which holds this. So you can just put this under the electricity. Now the undersurface emits, it has some bulb which emits the UV radiation. This UV radiation passes through a filter in such a way that only 365 nanometers pass through it, and this is made up of nickel oxide and barium silicate. Nickel oxide and barium silicate. Nickel oxide and barium silicate, yes. It is nickel oxide and barium silicate. Barium silicate. So option number 2 is the correct answer. Ruhi, any confusion? Any confusion? Ruhi, Jayashruti, Ashima, Swati. The image shows a bacterial infection. Identify the incorrect statement regarding the diagnosis. What is the correct answer here? Anyone? Very nice. The image shows a bacterial infection. Identify the incorrect statement regarding the diagnosis. The correct answer of this question is option number 3. Can you tell me what is the diagnosis? Can anybody tell me what is the diagnosis? Please remember, this is a very classical example of or image of erysipelas. It's a very classical image of erysipelas. Now what happened in these individuals? You have infection of the dermal lymphatics. Streptococcal infection of dermal lymphatics. Because dermis is a tight component, you will see well defined and raised borders. And this condition is also known as Saint Anthony fire. Now sometimes you get confused with erysipelas of the face and cellulitis of the face. To differentiate both of them, we have to look for the skin of the pinna. If pinna is involved, it is always erysipelas, because in ear pinna you have dermal component but there is no subcutaneous tissue. So in cellulitis patients you will not see involvement of ear pinna, because in cellulitis the inflammation is that of the subcutaneous tissue. But in erysipelas the infection is of the dermal component And because dermal component is present in the ear, you will see the involvement of the pinna in erysipelas. So this statement, option number 3, becomes incorrect. Option number 3 becomes incorrect here. Is that clear to all of you? So this is the difference. You can see that erysipelas have a very well defined border, while cellulitis have a ill defined border. And if there is involvement of the ear, which is seen in erysipelas, it is known as million ear sign, but cellulitis does not involve in the ear. So that is a very important difference which help us differentiate the cellulitis of the face from the erysipelas. My next question is, erysipeloid is transmitted by? Erysipeloid is transmitted by droplet, parasite, mosquito bite, or contact with the animal. Anyone can tell me the answer here? What is erysipeloid? Now first of all, you should know what is the meaning of erysipeloid. What do you mean by erysipeloid? Erysipeloid means erysipelas like. Erysipeloid means erysipelas like, and here the infection is transmitted by the contact of the animal. So look at this. Erysipeloid is the infection which occurs secondary to erysipelotrix roseopathy. It is more common in the individual who handle fish and raw meat, and erysipelas or cellulitis, both of these presentations can be seen. But because the causative organism is not Streptococcus, it is erysipelotrix roseopathy, we are not calling it as erysipelas, we are calling it as erysipelas like, that is erysipeloid. Clear? Erysipeloid simply means erysipelas like. The clinical presentation is similar to erysipelas, but the causative organism differs. Psychosis barbae is caused by. What is psychosis barbae and how does it occur? Anyone? Ashima, Jay, Shruti, Ruhi? Anyone? Psychosis barbae is caused by. Very nice. Amazing. Now psychosis barbae is caused by, please remember, psychosis barbae is nothing but folliculitis of the beard area, and the most common organism is Staphylococcus aureus. Can you see this? I hope the image is clear to all of you. This is the deep folliculitis of the beard area, this part, and it occurs very frequently in young males who do shaving in different directions. When patients do shaving in different directions, sometimes the hair grows inside. This will cause infection of the underlying part and it will cause folliculitis like feature. So deep folliculitis of the beard area is psychosis barbae secondary to Staphylococcus. We have two types of folliculitis. One is superficial, where only the upper part of the hair is affected, and we have a deep folliculitis where the whole thickness of the epidermis is affected, of the hair is affected. Now if the hair is affected in the whole thickness, in addition if there is involvement of the surrounding skin, it is known as furuncle. Please tell me the correct answer here. The thick adherent crust are seen in which of the following bacterial infection? The correct answer of this question is ichthyma. Now ichthyma forms a thick black eschar. It forms a thick black eschar. Is it visible to all of you? Am I audible and visible? Now you can see this image. I can show you the image here. Can you see there is a thick black eschar which is present? A very thick scale-like thing or a crust-like thing which is attached to the skin. When this eschar is removed, you can see a shallow ulcer. This is a very characteristic presentation of ichthyma. It occurs very frequently by Streptococcus or Staphylococcus. Usually it is the extension of the untreated impetigo. We have another question. So we have read about ichthyma, but there is one more entity which is known as ichthyma gangrenosum. So which of the following organism causes ichthyma gangrenosum? Staphylococcus, Streptococcus, Pseudomonas or Clostridium? Ichthyma was by Staphylo and Strepto. But what about ichthyma gangrenosum? Is it same or different entity? Very nice, Dr. Adiba. Very nice, Dr. Ruhi. It is by Pseudomonas. So in the patients who are diabetic, who are immunocompromised, you see a little larger ichthyma lesions, and that large ichthyma lesions will have a thick eschar. When that eschar is removed, you can see shallow ulcer with a wide base. So this is known as ichthyma gangrenosum. Clear? Next question. So one thing I just wanted to mention here, that we have total 3 types of ichthymas. I want all my students to write it down. In dermatology, you will be hearing about ichthymas under 3 headings. Ichthyma pyogenicum, ichthyma gangrenosum, and ichthyma contagiosum. So ichthyma pyogenicum, gangrenosum and contagiosum. Now what about ichthyma pyogenicum? What about ichthyma pyogenicum? It is the ichthyma secondary to Streptococcus or Staphylococcus. Gangrenosum was secondary to Pseudomonas, while ichthyma contagiosum is a viral infection secondary to Orf virus or a parapox virus. It is a Orf infection or a parapox viral infection. I hope this point is clear and nobody have any confusion with that. So just remember 3 places where you can get this word ichthyma. Ichthyma pyogenicum, ichthyma gangrenosum and ichthyma contagiosum. The next question is on your computer screen. Please tell me the correct answer. A 35-year-old male from Bihar comes with complaints of hypopigmented macule over the trunk and face. The nerves and sensations are tested to be normal. No scaling is visible in the lesion. The patient gives a history of prolonged fever of 2 years for which he was treated. What is the drug of choice for the patient's condition? Can you tell me the answer here? Can you tell me what is the correct answer here? Very nice, all of you. Now in this question, a very important clue is the patient gives a history of fever 2 years back for which he was treated. Now this history of fever in the past, it could be Kala Azar, that is visceral leishmaniasis, which presents with a prolonged fever. And right now, after few years of recovery from Kala Azar, patients started developing hypopigmented lesions. This is something which is known as post Kala Azar dermal leishmaniasis. And this is treated by giving oral miltefosine to the patients. Clear? So prolonged history, prolonged fever present 2 years back, and now patient developing hypopigmented lesions with no scaling, normal sensation. It has to be a patient of post Kala Azar dermal leishmaniasis. Now we can look at the lesions of leishmaniasis. We have a cutaneous leishmaniasis which presents with a cutaneous scar. So this is a cutaneous leishmaniasis. It presents with annular plaque with central crusting, and this type of ulcer is also known as volcano ulcer. Okay, this is volcano ulcer. Now the next is what is known as mucocutaneous leishmaniasis or a new world leishmaniasis, mucocutaneous. Here you will see the features of skin. Can you see that there is erosion? And you can also see the features of the mucous membrane involvement in the form of spondia. This is the involvement of the mucous membrane in the form of spondia. Is that clear to all of you? Can I get a quick thumbs up from all my dear students? So spondia and chiclero ulcer is a feature of mucocutaneous, while in visceral leishmaniasis we will see mainly the involvement of viscera, that is reticuloendothelial system like liver, spleen. Then the patient will have prolonged fever, night sweats, involvement of the lungs, etc. In PKDL, patient very characteristically develop hypopigmented lesions or nodular lesions, and for these patients the treatment of choice is oral methotrexate, which is drug of choice. Next question is on your screen. A 20-year-old male presented with erythematous nodule. The image is attached. Diascopy of the skin lesions reveals apple jelly nodules. What is the likely diagnosis? Anyone can tell me the diagnosis here? Very nice. We have just now read that this is a patient with annular lesion with central crusting, and that is a feature of cutaneous leishmaniasis. Annular lesion with central crusting. So in cutaneous leishmaniasis also we see apple jelly nodule, and in lupus vulgaris also we will see the apple jelly nodule. So these are some of the features which help us making the diagnosis. Is that clear to all of you? Can I get a quick thumbs up from everyone? Anybody has any confusion? No. Next. Which of the following is the vector of chiclero ulcer? Which of the following is the vector of chiclero ulcer? Which of the following is the vector of chiclero ulcer? Very nice. The vector is Lutzomia species. Chiclero ulcer is actually a form of mucocutaneous ulcer. The spondia and chiclero ulcer is mucocutaneous leishmaniasis. And for mucocutaneous leishmaniasis, the vector is chiclero ulcer, Lutzomia. But for the cutaneous leishmaniasis, which is the volcano ulcer or oriental sore, the vector is phlebotomous species. So there is a difference in both of them. What is volcano ulcer? Anyone? What is volcano ulcer? Volcano ulcer is nothing but another name for the oriental sore or cutaneous leishmaniasis lesion. Now we have discussed that these lesions are annular lesions. So when you look it from side, they are something like this, with a wide base and a narrow neck, and there is a lot of crust which is attached here. So it looks very similar to that of a volcano. So volcano sign is nothing but cutaneous lesion of cutaneous leishmaniasis. What is the causative agent of tinea nigra? Causative agent for tinea nigra? Anyone can tell me the answer here? Very nice. The causative agent for tinea nigra is Horte wernicke. Now this is a misnomer because it is not a dermatophytic infection. Although it says tinea, but this is not a dermatophyte. We usually use tinea word for a dermatophytic infection, but this is a misnomer because here the causative agent is a non-dermatophytic fungus, which is Horte wernicke. Now if you look at this image carefully, just look at this image. This is the, just a second, I have to charge my laptop, just give me a second. So I hope I am visible to all of you. Can you just give me a quick thumbs up? I hope I am audible and visible to all of you. So just look at this image. You can see some hyperpigmented macules which is present on the palmar aspect. These are nothing but the tinea nigra lesions. If you scratch them little deep, If you scratch them little deep, you can even remove these hyperpigmented lesions. So these are a very classical superficial fungal infection caused by Horte wernicke, which is not a dermatophyte infection. Now what is a dermatophyte infection then? What is a dermatophyte? Very nice. Jai Shruti, Arzu, Monica, Harsh, Ashima, Ruhi. Dermatophyte infection 2. Superficial, subdermal, subfacial or muscular. What is the correct answer here? Anyone? Dr. Adiba, very nice. It is a superficial part. And yes, you are right. Dermatophyte is a keratophilic fungus. It loves keratin. So keratin is present in which areas? It is present in the epidermis of the skin, it is present in hair, and present in nail. And that is why dermatophyte is the infection of all these three areas. We have divided the fungal infections into two broad categories, superficial and deep. Superficial includes dermatophyte, Pityriasis versicolor candida, and deep includes mycetoma, sporotrichosis and chromoblastomycosis. Dermatophyte is a superficial bacterial infection of skin, hair and nail. Now how to differentiate these three genera of dermatophyte? We will see the shape of the macroconidias. So can you see these three images? I hope it is visible to you. The macroconidias of microsporum is fusiform. The macroconidias of the microsporum species is fusiform. Of the trichophyton species is long, thin like a pencil. And the macroconidias of epidermophyton is club shaped. So these are the three methods which help us differentiate them on doing the microscopy. This is fusiform, this is club shaped, and this is linear. Fusiform, club shaped and linear. Now I have a question. Which of the following does not causes tinea capitis? Tinea capitis is what? It is the dermatophytic infection of the hair. Dermatophytic infection of the hair. Dermatophytic infection of the hair. So please tell me the correct answer. Trichophyton rubrum, epidermophyton microsporum or Trichophyton violaceum. Which does not causes tinea capitis? Which does not causes tinea capitis? Trichophyton, epidermophyton, microsporum or Trichophyton. Please remember, there are three species. Trichophyton affects all three: skin, hair and nail. Epidermophyton affects only the skin and the nails. So E will not affect the H. Similarly, M will not affect the N, that is nail. It affects the skin, it affects the hair. So E will not affect. The answer becomes this. Understood or not? Trichophyton affects all three. Microsporum do not affect nail and epidermophyton do not affect the hair. Let me change the color of the background. I think it becomes more easy for you to. I think this would be better. Yes. I hope now you all can see this properly. So Trichophyton affects all three. Microsporum, after M comes N in your alphabet. So M will not affect N and E will not affect H. So you will never get tinea unguum, which is the dermatophytic infection of nail, through microsporum species, and you will never get the dermatophytic infection of the hair, that is tinea capitis, secondary to that of the epidermophyton species. Clear? I hope this point is very easy. Clear hai? Can I get a very quick thumbs up from all my dear students? Nice. Dermatophyte are. Tell me the answer. What is a dermatophyte? Sporothrix, tinea versicolor, chromoblastomycosis or Trichophyton rubrum. We have discussed that there are 3 species. Very nice, Ruhi, Ashima, Adina. Dermatophytes are amazing. The correct answer is, it is the Trichophyton species. Trichophyton. Now with this we are done with the today's session. I thank to all my dear students for your presence. I request all of you to please subscribe to Unacademy using this code CHESTA10. Get your subscription using this code. Using this code CHESTA10 to get 10% additional discount on the subscription fees. We have one more session today at 9 p.m. I would love to see all of you there at the 9 p.m. session also. Till then,